Alrighty, so we're just going to go ahead and give about 2 minutes and allow attendees to join. We'll start at 12:02 sharp. Alrighty, we'll go ahead and we'll give it just 1 more minute. All right, we'll go ahead and we will get started. Hello and welcome to today's webinar, Surprising Insights from Your Urgent Care Payer Data. My name is Samantha Burke and I am NERUCA's Administrative Director. I'll be your moderator today. This webinar, we're really excited, is co-sponsored with Aptitude. But before we start, I'm gonna go over some quick housekeeping items. Friendly heads up, today's webinar is being recorded and we invite you to submit your questions by using the Q&A box at the bottom right of the screen. And for those of you who don't know, NERUCA is in its 11th year of existence. And today we provide a couple different things, specifically grassroots local representation in partnership with UCA's National Strength. We also tackle legislative issues at the state level, and we provide education and advocacy for urgent care medicine in the Northeast region. We do this through programming, including today's webinar and our annual conference, which is our signature event of the year. Now, our next conference is going to be held at Foxwoods in Connecticut. It'll be held from September 28th to the 30th, and please keep your eyes out for a save the date to come. And lastly, I would like to thank our platinum sponsors for the continuing support. Shout out to BD, to Xperity, to HealthTrack RX, Medline, and last but not least, today's sponsor, Aptitude. Those interested in either sponsoring or exhibiting or perhaps even speaking should be receiving communication shortly. Please feel free to reach out to us if you are interested at admin@neruca.org. That is ADMIN at neruca.org with any questions or comments that you may have. Now, with that, it is my distinct pleasure to introduce you to today's speaker, Scott Ferguson, co-founder and CEO of Aptitude. Now, Aptitude has developed the Metrics platform, a type of new point of care molecular diagnostic system that really enables any practice to offer their patient lab quality accuracy on a spot and boost their bottom line at the same time. Scott is joined by co-founder and CEO Jackson Gong and Aptitude's head of clinical diagnostic solutions, Myung Lee. Now, you may have seen them at the UCA or NERUCA conference before. They're very actively involved in the industry, and we have acquired a lot of really cool data and insights about urgent care. In fact, Scott actually just told me that he's been invited by the UCA to be a speaker at the 2025 National Convention. So in today's webinar, we're going to get an early preview of that talk. So without further ado, I'm going to toss it over to you, Scott.
Awesome. Thank you so much, Samantha, for the kind introduction. And thank you for the opportunity to get to speak today. So hello, everyone, and thanks for joining us. We're excited to share some surprising insights that we hope could be impactful for your practice. So let's get started with a question. So who can guess what the net income average for urgent cares across the country is? Well, unfortunately, the answer is 0. And this is a problem. And how big of a problem? A pretty massive problem at the country level. Half of the country is counting on urgent care, with about 160 million visits annually. So considering there's about 130 million households, that's more than one visit per household per year. And that reliance is rising. We all know, of course, about the COVID spike and the following contraction, but we can see that the underlying trend of growth is still there. And I think we know this intuitively. The majority of millennials and Gen Zs count on urgent care like a PCP, and that pattern is increasing. And so it's fair to say that urgent care is like the front door of healthcare in this country. But with zero average net income, we need to work hard to make sure that door doesn't get boarded up. And so making urgent cares viable is vital to this country's healthcare. And I know that you already understand this deeply. And so far, I'm just preaching to the choir. And so my goal today isn't to tell you what you already know. We're here to share some new insights that you can actually do something about. And so we want to help. And at Aptitude, we build next generation, as Samantha said, next generation molecular diagnostics that enable practices to deliver better medicine and get better margins. But we're not just a device company. At our core, we seek to understand problems and solve them. We do that in our R&D and product development work, but we also do it to serve our customers in the best way we possibly can. And so in serving you, we've already learned a lot about the challenges that you're facing and how different each urgent care is. And so we didn't stop at building devices. We're also building tools that allow us to synthesize provider, payer, and product data so we can better understand how we can actually help individual practices. We've so far verified our initial insights with a number of urgent care leaders. And even though we've just begun to scratch the surface, we're already eager to share that learning with you so you can begin to already deliver better medicine and make better margins. So we know that the average urgent care net income is zero, but the good news is that means that there's some practices that are actually doing well. And it's true, there's practices that are not. We can learn from those winners and also the losers to discern some strategies that can make sure that, that you're doing as well as possible. So how do we actually do it? Well, we mine these little nuggets from data that cover over 300 million lives in practices that are all across the country, and they emphasize urgent cares. So this includes claims data, payer transparency data, and distributor product sales data. And so by combining these sources, we can zoom out countrywide or statewide, or drill all the way down and look at each individual practice. So we can check out a given practice, we can see its visits by ICD-10 code, we can see the corresponding diagnostic procedures that are rendered in that visit, and we can see what you're charging your payers, who those payers are and how much they should be paying. And we can also see how much those tests cost. And so taken together, I don't want to say this is perfect information, but taken together, we can get a general financial picture that's specific to your practice. And so let's start to look for some insights, beginning with urgent care's #1 use case, respiratory. So respiratory visits are responsible for about 40% of urgent care visits. It's by far the #1. Now, you probably know this already, but it's worth stressing how we got this number. This is not from some industry white paper. This is us looking directly at the claims data across all the urgent care practices in the country and directly determining which codes actually drive your visits. This is just the first thread that we're pulling here. And so the question is, if we all know that respiratory is #1, and that's obvious, do we all know how to make the most of those visits? And surprisingly, the answer is no. Urgent cares get paid very differently when it comes to respiratory visits. And so even for the same visit type, different practices have hugely different average charges. So we can check out, for example, a very narrowly defined region. Take New York City, the plot we're showing here on the right. And we can pick the top principal ICD-10 code, acute respiratory infection. even for this very narrowly defined criteria, we can already see a 3x spread in charges. And it's not just in this instance. This isn't cherry-picked. We can see this same trend in any location around the country. And it begs the question, why are some practices charging a lot more than others? Well, fortunately, we can see every diagnostic procedure that's being done for a given visit in ICD-10 code. So we can actually answer the question, what are practices actually doing with these patients? And it turns out they're treating them very differently. And so some urgent cares, for example, a patient may show up with a primary principal acute respiratory case, and you'd get a test on the spot maybe half the time. Well, that same patient showing up to another urgent care might get 2 tests. And so that's a 4-fold spread right there. So what does this actually have to do with solving that problem I mentioned at the start, the zero average net income problem? Well, remember, the majority of urgent care visits are fee-for-service visits. And so that means the more medically justified and appropriate services you provide, the more you get paid. And so here we're showing across the country that most states are well above 50% fee-for-service. And many providers are much higher still. And so the more service you provide, the more payment in those fee-for-service practices. And so given that information, we might expect that practices with higher fee-for-service rates would run more tests. And it turns out that some practices do, but other practices don't. And we've plotted that here. We've taken the practices with fee-for-service rate on the x-axis and the average number of tests performed per respiratory visit on the y-axis. And what we can see here is that there's a loose trend upwards and to the right. And these guys up here above the line have a high fee-for-service rate and are performing a high level of service, as they should and as we'd expect. But those with the low fee-for-service rates, who are over here, they're providing generally a lower level of service, which is also what we would expect. There's a group of saints here, they're fairly rare, that are providing a high-level service with a low level of fee-for-service. So they're not really getting paid for it. But what's particularly curious is this group on the lower right, which have a very high fee-for-service level, but for some reason have a low level of tests. And so what we found is that many practices are not aware of their total fee-for-service rate. And so they could be running far fewer tests than they actually should. So we can actually take a look at these individual practices to see the impact. And let's just zoom in on a couple that are very close. So if we take a look at a couple of clinics, these ones are in Virginia. So these are 2 similar clinics, the same state, same great fee-for-service rate, roughly between 70 to 85%. And there's a big difference, though. One of the one on the left, or sorry, these also have similar patient flow, around 15,000 annual respiratory visits. The practice on the left has, on average, about 1 diagnostic procedure per visit, whereas the clinic, otherwise same type of clinic, has 2.2 diagnostic procedures per visit on the right. And the impact of that is significant. So if we assume an incremental profit per 10,000 tests that are run at about $25 profit per test, that translates to about a $300,000 increase in net profit per year that this other practice would be seeing. So that's over a 2-fold increase in profitability. So this is what we mean by better margins. This one clinic has significantly better margins than the one on the left. And in terms of better medicine, this concept of testing more appropriately on the spot is also better medicine. So patients go to urgent care to get timely treatments. And even in the absence of an applicable treatment, patients are more satisfied when they get to understand what bug they've actually got right then and there. And so point of care testing is more rapidly actionable, and it provides the clarity that patients really crave right on the spot. So it's good for patients as well. So insight number one is to test more. And no, we're not talking about running up a bunch of unnecessary tests. Many practices, what we found, have the ICD-10 codes that justify and warrant testing, but are just not doing the associated testing. It could be because they're doing a lot of send-outs or just not doing that many tests themselves. And so it's leaving money on the table, and it leaves the patient in a lurch. So you can improve your bottom line in patient experience by running tests that are appropriate for that ICD-10. Okay, so test more, all right, but what type of test should be used? This is also a very important question because not all tests are the same, both financially and medically. So let's give a recap of the different types of tests that are out there. So the first type is manual antigen. So you've seen these before, I'm sure. So many of you are running them. So these are like the BinaxNOW, FlowFlex, QuickView, the ones that you see the actual lines on and interpret yourself. So you run these things manually. So these are very common. The other type are the reader-based antigen tests. There was a talk from BD, I think yesterday, from NERUCA. So the BD Veritor is one of these types of tests. The Sophia and of course the Abbott Digival. So these basically take those same antigen tests and interpret the results for you automatically. They can also integrate with EHR and help take care of simplifications on the back end. So these are the two primary ways that antigen tests are run. And the third type of test is point of care molecular. So these are like the same type of PCR performance that you get with a send out going to a high complexity CLIA lab, but you can actually get those results done on the spot in the CLIA-Wave setting itself. And so here we have, for example, the Abbott ID Now, the Cephia Gene Expert, and on the right we have the Aptitude Metrics next generation molecular diagnostic platform. And so these are the types of tests. And right off the bat, if you're thinking about which test to pick from a medical standpoint, molecular is better medicine. These tests are about 1,000 times more sensitive. And so that means that you don't miss positive cases early in an infection when the viral loads are quite a bit lower and can be readily missed with antigen tests. That's really important because the treatments that are available, for example, Paxlovid, Tamiflu, et cetera, are generally much more effective when given earlier in the course of the illness. And so being able to catch those conditions early and treat early is better for the patients. And who likes to find out they got the wrong result at the urgent care afterwards as well. So a more reliable result up front is really important. The other thing is it can simplify the care. So with antigen tests, I mean, these have the FDA label that they require serial testing. And so that means in the instance of a negative, you're actually supposed to test again, usually a couple days later. And that means in the event of a negative, either the patient has to go home and test themselves again, or you got to do a send out and they get a confirmatory result later on. And so that makes the care more complex for the patient, and it lacks clarity in that visit. And so the other part, of course, is to boost patient satisfaction. So patients are aware of antigen testing. They've been getting them for free in the mail. They can go and pick up them at the corner store. And not giving the patient the same thing that they pick up there at that corner store is a big deal. They're showing up at the urgent care for quality. So in summary, you only have a short time with your patient. And you can make that precious visit really count by giving the best clarity that medicine can offer on the spot. And if we think about it from the price standpoint, molecular can give better margins as well. So this is really important point as well. If we zoom in and check out, as an example, a COVID flu combo test for antigen and for molecular, you probably already know this. It has significantly higher reimbursement for molecular. So we're showing that here. There's this CPT codes for manual antigen and reader antigen, as well as point of care molecular down there. We have the corresponding reimbursement code. So it's more than double for the CMS reimbursement. But you're probably also aware that the average sales price for molecular tends to be a lot higher. And that's certainly the case for Cepheid and Abbott. So around $70, that's quite a bit higher than those. And also, they generally require contracts and minimums, which make purchasing those tests a little more challenging. So even though you could get a higher profit with a traditional molecular system, sometimes those contract commitments turn people off of being able to do it. And so what's interesting is with metrics as this next generation molecular test, so it's a much, much simpler system. And that simplicity means that it doesn't need to cost so much. So you can make significantly more with metrics. So with the average sales price significantly lower, the profit becomes more than double what you can get with antigen. And because the system is much simpler as well, this doesn't require those types of contracts with minimums that can be scary for an urgent care practice to adopt. So this really can dramatically increase the accessibility of molecular tests from a financial perspective. So how does this actually look when we consider the commercial payers? Those were the CMS rates that we shared previously. So what does this actually look like with commercial payers? So we took the time to evaluate the prior payer transparency data. And so we were able to look at the top payers across the country and see how much the contracted rates really are for the different types of tests at the different providers. And we can see that molecular really does indeed pay significantly better than antigen. This is for the, again, for the COVID flu combo CPT codes for molecular and antigen. And so we can see that the median for molecular COVID flu is about $83 higher than for the antigen combo. And we do have a spread. And so again, the specifics matter at the individual practice. And so generally though, the median is a significantly better improvement. So that's with the payer data. So how does this actually affect how does the case rate? So we know, I mentioned before that most practices have mostly fee-for-service, but how does that actually impact the P&L when case rate is involved? And so, well, we know that case rate basically hurts the P&L in general. So you get a fixed reimbursement for a visit. So the incentive there is really for providers to minimize their service. And so in that instance, it's important to take a look how those different case rate scenarios can impact the economics of the test choice. And so to do that, we're looking at each of the individual tests we gave on the previous example. So we have a CorDX, visual antigen, Sophia, reader-based antigen, Cepheid, traditional point-of-care molecular, and Metrics, next-gen molecular. And we have their average sales price, and we have the average reimbursement shown on this table here. And what we're trying to look at is how the fee-for-service rate, i.e. 1 minus the case rate, affects the P&L across 10,000 tests. And so what we can see is For Cepheid, even though it does have a higher per profit as a traditional molecular test versus the antigen test, as the fee-for-service rate begins to drop, it becomes less preferable to use. And in fact, at a 40% fee-for-service rate, you would start losing money with the Cepheid system, whereas you still stay in the black with the antigen systems. But what's interesting to note is that the metric system combines a low cost for the consumable, low cost reader, and excellent reimbursement. It's much more robust against different fee-for-service rates. And so it actually comes out on top at each one of these examples. And so, so basically, the metric system is quite robust in the face of different payer mix and also fee-for-service rates. So this, of course, begs the question, how does this actually translate into real-world clinics? Does this analysis actually hold up? And so we're fortunate to work with Todd Martin at Emergency One, who has run the numbers at his clinic. And what we're able to see in this analysis here is, if we look on the left, we see the different payers that are in Todd's practice. We have in this table a comparison between the Sophia antigen test for the COVID flu combo and the Metrics molecular COVID flu combo. And so we can see the individual payers' reimbursement for those specific tests. We can see the cost of those tests and calculate the profit. And based on the respective payer volume for each one of those payers, we can calculate the profit or loss for those specific patients, treating them all the same. And so what we can show here is that, yes, some patients who are in the case rate example, they're in the red on this P&L, as we'd expect. You don't get an incremental payment for those case rate cases, but those who are in the black can hugely offset those case rate cases, and you, in Todd's case, can actually make 5-fold the profit with metrics compared to antigen. So this is a really big deal. So molecular, so the better medicine part, and improved profit, better margins, is able to come true with the metrics platform in a real clinic example. And another way to combat that global rate problem is not just through the robustness of the reimbursement and the cost aspect of the test itself. Some practices actually combat that global rate challenge by trying to stop subsidizing those global rate contracts with the fee-for-service contracts. And some practices actually tailor their testing methods based on the payers that a given patient may have. And other practices also just try to inject more clarity into the practice. Like in this case here, where these are the Cepheid consumables, the operators have actually written the cost for these specific tests on the boxes, as well as their associated reimbursement rates, so that the person in the moment is able to actually see what's at stake here when they're making their testing choice. So you can approach it uniformly across the practice, in which case, a higher reimbursement and higher and lower costs can weather the effects of a wonky payer mix, or you can try to be more tailored in the approach in approaching the individual patient and their associated payers. So insight number 1 was to test appropriately more. Insight 2 is to do it with the right test. And so from a medical perspective, once again, molecular is clearly the better test. Traditional molecular can be better, but given the high cost of consumables and contract minimums to cover the equipment, it can be a scary investment. And so metrics really fixes that. So in short, you can make a lot more money and do your patients right with metrics. And so you may wonder, does this actually apply to me? I really want to stress the data that we present today is by no means perfect. This stuff really is complex, and each of these sources has their caveats as well. However, they do provide powerful directional guidance and an excellent starting point for a deeper dive. And so, if you're wondering, do these insights actually apply to you? Well, very likely so. You can check for yourself. You can check your payment management system, your EMR, or your payer fee schedules. You don't need to be a CFO to get a decent handle on this. Or you can come and talk with us. We can work with you, your coder or other personnel, and we can generate a snapshot just like we shared with the Todd Martin example. And so we can model it and then we can prove it out. And so your own practice, it may surprise you. And perhaps you can help to raise that urgent care net average income deeper into the black. And so with that, I'd really like to thank you for the opportunity to speak today. And we really want to be able to get in touch with you to help. And so if you have any questions, I'd like to devote the rest of the time to answer those questions. Thank you so much.
Thank you so much, Scott, for sharing your valuable insights. They've really given us a great deal to think about as we move forward. So now we're going to go ahead and we're going to open up the floor for some questions. This is really just a great opportunity to dive deeper into some of those topics that we've covered, or even address any of specific thoughts or concerns that you may have. So again, as a friendly reminder, feel free to submit your questions in the chat box, and we'll get to as many as possible in the time that we have. So I'm just going to take a quick look. We'll start off with the first question I'm seeing here. So what you're telling me is that I need to test more and use molecular test, question mark. Why did you need fancy databases to tell me
that? Jackson, do you want to answer that?
Absolutely. Yeah, this is a great question. My name is Jackson Gong. I'm the co-founder and COO of Aptitude. Well, yeah, if you already know your payer mix, your price for different tests, and their reimbursement, their CPT code with different payers, if you know all these by heart, well, you're the type of savvy operators we're talking about, and you're probably already doing fine. You're already following the best practice. Well, however, as Scott mentioned, and our database actually allow us to look at the practice pattern of every clinic in the nation. And what we actually found is that a lot of the clinics are not making the right choices for their business and for their patients as well. And this is also, to be honest, consistent with our discussion with operators. I went to a lot of different places, just visiting clinics on site and see what they're doing. And what we found is that not everyone, you know, uh, fully recognize the significant impact of payer mix, of the right respiratory testing strategy on their bottom line. So we feel this is worth sharing. And as we dive deeper into the data, I think we will uncover more tips, and we will continue to share those new learnings with everyone in the future. And another thing I want to say is, let's say you know all those information before. What are you going to do with that? Because a lot of those clinics, they may in theory benefit from using molecular, but they probably still don't do that, and for good reason, because well, again, as Scott mentioned, the previous molecular tests have both high price and multi-year contract. So that's scary, right? Because what if your peer mix suddenly changed? What if your patient visit, your dynamics suddenly changed? That's going to leave you with a pretty big risk. Well, fortunately, as Scott presented, well, metrics literally change the equation here, right? As long as your practice is about 40% fee for service, you're probably financially better off with metrics, and it provides better medicine for your patient, and it doesn't have contract, so you have no downside risk. So our data shows that really most clinics in the country are above that 40% mark. So please, check your situation. If you are above that, talk to us, and we can help you work through the details. And you may find that metrics is a better option for your respiratory testing.
Great response and great question. And thanks so much for sharing. I'm going to go ahead and pull up another question that we just received. Looks like this one says, what are the databases that you have access to? And how easy is it to synthesize the data to run the analyses that you're showing here?
Cool. Yeah, that's a great question. So I think what's most important is to emphasize the types of databases that we're utilizing here. So one of these is essentially claims data. So these are databases that gather claims from clearinghouses, so we can see this is basically how we're able to see all of the visits, the ICD-10 codes, the charges, the CPT codes associated with those as well. So that's one aspect. And then the payer transparency data is what helps us to understand at least what the contracted rate should be with the individual payers. And then the third type of database is it's just real world sales data. So we can see the spread, we can see the median. Basically, we can get the deep information on the products that are being offered to urgent cares and what they should really be expecting to pay for those. And so by synthesizing these databases, we can generate these insights. And so that synthesis is not easy. We've had to develop a bunch of data analytics tools to pull this stuff together and make sense of it and validate it. And so it's not easy to be able to set that up. But now it's fairly straightforward for us to work directly with individual practices to be able to provide those types of tailored insights on a practice by practice basis.
Great, thank you so much again. I've got another question coming in from an anonymous user. What is the difference between metrics and the other molecular platforms that you listed?
Yeah, so very good question. So let's start with what they're the same about. So basically, they're both molecular tests. So these are like PCR quality, extremely sensitive, about 1,000 times more sensitive than antigen tests. So that part is the same. The part that's different is that like the way that metrics works is it's just dramatically simpler. We've hugely simplifies the architecture of these devices. And so that allows the cost for this product to be much lower. We're passing that on to the customers. And then in terms of other differences, metrics is super fast. It's faster than the Cepheid. It's faster than running two separate COVID and flu tests with the ID Now. It's very simple. It's been built essentially for lay users, and so it's very accessible for a professional clinic to be able to execute these things. So I think that's the primary difference is we built this thing to be just dramatically more accessible. So people don't have those scary things that Jackson was talking about when facing the option for molecular.
Great, thank you so much again. I've got another question coming in, and this one reads, when will your COVID/flu product be available? What would be the cost for both the readers and the consumables? I heard that there is no contract with the readers. Is that correct?
Yes, I can answer this question. So our Matrix COVID flu product is in a late stage of FDA review right now. We're targeting to launch the product within this flu season. So we're very excited for this launch. So if you're interested in working with us, please reach out to either me or Liang, and we will put you in our priority list. So once we got official authorization, we can start working with you. And yes, correct. There's no contract. The sticker price for our reader is $50. We obviously will give it to you for free as the starter bundle. We partner with Security Diagnostics on this product, and will be available through all the major distributors. So you can buy our product no matter which distributor you work with. So because it goes through distribution, we cannot really control their listing price. But if you're interested, again, please talk to us. We'll work with you to get your test cost down to $40 per test, because we want to really encourage people to adopt this new platform so you can see for yourself how it can benefit your practice.
Perfect. Thanks so much. I've got another question coming in saying, do you have any other products besides the COVID/flu?
Yeah, I can take this one. So I'm Liang Li, heading the clinical diagnostic solutions at Aptitude. And thank you for asking that question. And yes, we have a COVID flu test already on the market. And our goal is to really offer a complete respiratory menu to your clinics to cover the 40% of the urgent care visits. Therefore, we are expanding the menu with the 2 additional products. One is a respiratory panel, including at least the RSV, and another is a strep A test. Beyond the respiratory, we also want to address your testing needs in sexual health. So our CT/NG TB test is in late development. So we hope to launch all these 3 tests in the next 2 years, basically.
Great. Thanks so much. Let's see here. A couple others coming in. One reads, you presented a case study that compared antigen versus molecular in a specific practice. Is that something that your team can help me do at my urgent care?
Yeah, I can take this. Absolutely. Yeah, so I think you're referring to the slide where Scott shows Todd Martin's analysis. Well, Todd did his research on his own, one of those savvy operators. But yeah, we would be more than happy to help you with the same type of exercise. 'Cause, what we really believe is that we want to, present all the data to the operators so they can make an informed decision what make the most sense for their practice. So we are very happy to work with you to do the exercise and build a model that you can use in the future even as your situation evolves.
Great. Thank you so much. Let's see here. Another question reads, why is anyone bothering with reader antigens when the visual ones look so good price-wise?
Right. I think, what we want to do here is, we want to be an ally of the urgent care industry. And I think, we shouldn't, shy away from talking about economics. But then economics does, manifest in multiple different ways, right? Like there's clinical value, there's, pure price, and there's, time saving, benefit to quality, etc. So if we look at, visual antigen and reader antigen, clinically, well, they have similar performance as Scott presented. However, reader antigen, by having the reader and the software, it does provide some useful functionalities, right? It can store the results, it can print out the result for quality compliance needs, and it can also just automatically transmit data to EHR to save your staff time and to eliminate any manual errors. So for some operators, these benefits can justify the additional cost. Like for example, in Todd's clinic, everything is connected to EHR, and that's a significant saving for his staff. Now, I want to emphasize Matrix has all these advantages as well. We're developing the Matrix station that can run multiple readers simultaneously, have data storage and printing, and will connect with your EHR as well. So if you're sticking with a reader option for those additional functionality, again, please talk to us, and we have a solution that can meet your needs as well.
Amazing. Thanks so much. And we've got quite a few questions in the chat, so we'll go ahead and we'll keep going. The next one that I see coming in is it true that if we do work with you, that we would use your data for free?
Yeah, I mean, I can answer that as well. Again, as Scott, emphasized, we want to, help out, right? We want to be an ally to the industry in general. So if we find some general trends, some general insights, we want to share that with everybody. You don't even need to work with us. No matter whether you work with us or not, we wish the best for you. But if you do work with us, obviously, we really want you to be as successful as possible with our product. So if more data is helpful for you, yeah, we will provide more data, no problem. I also want to say we have other expertise as well that we can share. Like, for example, we're quite familiar with insurance billing, like during the pandemic, we actually operated our own high complexity CLIA lab. We did, almost 500,000 tests, and we did all the bidding ourselves. So yeah, there are other ways we can contribute our expertise if you work with us. Yeah, we're the kind of company that rolls up our sleeve to help our customer.
Awesome. Awesome. Thank you so much. And again, like I said, we've got quite a bit of questions in the Q&A chat. I have another one coming from an anonymous. This one reads, when is the metrics combo test coming out?
Right. So as I mentioned, we are targeting to launch the product within this flu season. So we don't have the specific dating, but we are prepared to launch as soon as possible. So please talk to us so we can reach out to you once we receive the official authorization.
Got it. And who should we talk to for more information?
So yeah, as Scott and Jackson mentioned earlier, basically your success is really our priority. Our goal is to help you make an informed decision on adopting our metrics platform. And we are committed to working with you to make sure our product actually fits your clinic's needs financially, operationally, and clinically. So yeah, please reach out to me or Jackson or Scott for more information about our product. And our contact information is listed on the slide showing here.
Great, thank you so much. I've got one coming in asking, do you have any plans on making a higher plex respiratory panel in the future? And what are the max multiplexing limitations of your assay?
Yeah, I can answer that. I think Liang already touched on that point. So yeah, the short answer is yes. We're gonna expand the panel to include RSV, and we have plans beyond that as well. The platform is quite robust. We can support up to actually 8 plex on the device as is, and so the expanded potential panels that we can run on this are quite significant. So if you have certain interests and needs that you want addressed from our product development team, we also love to gather those insights too. So feel free to follow up with us on that too.
Great, thanks so much. And just in case, I do see another one coming in saying, what is the time to result of the aptitude test?
20 minutes.
Yeah, just putting that into a context. This is really, a big step up compared to our competitors. Scott already mentioned, but I think it's worth really highlighting. So yeah, if we're looking at molecular, they have quite a bit of a complexity, right? Scott already mentioned it's high price typically, and it's typically a multi-year contract. We solve all of those problems. And another thing is they traditionally just take longer to run. Like Cepheid has a turnaround time of 36 minutes. Now, Abbott is faster, but unfortunately, Abbott doesn't have a combo test. So if you run 2 Abbott ID Now tests, again, you're looking at 30 minutes. And as we talk to urgent care operators, everybody expressed to us, yeah, they want short turnaround time. They want around 20-minute turnaround time, and we deliver that. And really, we're the only one that are able to give you this low cost and fast turnaround time to meet your workflow. And with our future product, again, it will be faster turnaround time than other molecular tests as well.
Yeah, and just to add on to that, from the perspective of value add time for your staff time as well, the metric system is quite a bit simpler. So it's much faster to execute than, for example, the ID Now. That requires quite a bit more hands-on time and just sitting by the machine as well to execute the following tests. It's less than a minute of hands-on time, just a few seconds.
Great, thank you so much for elaborating on those as well. I've got another question coming in asking, are you going to send free samples?
Yes, this is something we can certainly do. Again, we encourage people just to talk to us. What we want to do is to help you make an informed decision, right? So that means we want to talk to you to make sure, well, it makes sense for you on all sorts of front. on the financial front, whether this is a good investment for you, and on the workflow front, whether there's any issue you're concerned about. And yeah, after you talk to us, if you realize, okay, this sounds like an interesting platform, but you just want to test out a couple to make sure, we can definitely do that. That's not a problem at all.
Great, thank you for clarifying, Jackson. I've got another question coming in. It's a bit of a paragraph, so I'll go ahead and I'll read briefly here. Observing most of the urgent care centers are sending out for molecular testing for combo test. This is another impact of advocating the urgent care centers to maximize the revenue. How can we advocate this info to urgent care centers?
Right, I think I can take this question. So it's interesting, right? People send out those molecular tests. I honestly don't know what's the reason, but I can guess, right? One guess is these urgent care center actually recognize the value of molecular test, right? They want to do the right thing for their patient. But unfortunately, they either just don't have a good fee-for-service rate that can justify doing molecular tests in-house, or maybe they previously used other molecular tests. They may get burned by those other molecular tests. We heard horror story, about that. I think you guys also did, but let's we don't need to dive into that. But yeah, they may just decide to steer away from molecular internally, but they also still know that molecular is the right thing for their patient. So what do? Well, they're gonna need to send it out to the lab. So we actually appreciate the thoughtfulness of these operators. But what we want to really, again, emphasize is metrics change the equation. Metrics change the calculation for adopting molecular. So for those urgent care operators who, well, on one hand, recognize the value of molecular, but on the other hand, previously, for whatever reason, didn't choose molecular, well, give molecular a chance, give metrics a chance, talk to us. And again, we will walk through the details so that you can make an informed decision whether it makes sense to take the molecular back in-house. Again, it will be clearly better for the patient. You give your patient lab quality result within the same visit, right? Instead of waiting for several days. And then you also retain the revenue. With send-out, obviously, you don't get to do that.
Thank you so much. I've got another question coming in. We've got quite a bit of engagement here from the Q&A, so really appreciate that to the audience. The question reads, would the price go up from $40 when you add RSV?
Well, that's a CEO question.
Yeah, I don't think we finalized our pricing strategy for that subsequent product, but I can still say that you can tell what we're trying to do here. Our commitment is to really deliver value, and we're trying to break barriers here to be able to improve accessibility of this type of molecular testing. So even though I can't say what the specific pricing of that product would be at the time, you can know that we're coming from a place of increasing accessibility. So I know that's vague, but I think that's the best I can say right now.
Well, I think I can add one more thing. We obviously have not done the practice exercise to determine the price, but Scott and me and our other co-founder JP, we as the leader of the company, we set the vision of the company to be providing the most affordable and user-friendly molecular test possible to the end users. So yeah, you can count on us giving you really the best product at the best pricing. And I hope you will see with the most helpful customer support as well.
Thank you so much. We're going to go ahead and read a couple more questions left because I know we're getting a little low on time here. Another question reads, what is the limit of detection and PPA/NPA numbers compared to Sheffield or something similar?
Leon, would you like to?
Scott, you want me to take this? Yeah. So yes, this is actually another great question. So it's kind of probably surprising that such a small instrument can achieve such a good performance, but it is true. In fact, you can look at our COVID EUA submission on FDA website. This is public information. For our COVID product that's already on the market, we got a 97% sensitivity and 99% specificity. And with our COVID flu combo test, across the board, COVID, flu A, flu B, we all achieve more than 95% sensitivity and 99% specificity. And I also want to emphasize, we compared against really top line lab tests. This is a really comparable to the gold standard lab tests out there. So we are really comparable performance with the leading molecular test, but we're offering it at significantly lower price, no contract obligation, and the best user experience as well.
Great, thank you so much, Jackson. I'm gonna read just one more question because we're approaching that time limit. But the final question that we'll read here today asks, will the pricing be lower if we take from multiple urgent care sites?
Right. So I encourage you to just talk to us, and we will work with you to work out all those details. So what I can say right now is we believe in the long-term potential of this platform, and we want to remove all the roadblocks to implementing our product into as many practices as possible, so they can see the value, the benefit of our platform with their own eyes, and after they actually use our product. So if pricing is the final roadblock, everything else looks well, yeah, let's talk about it. We are our entrepreneurial company, and we can really just work with you to come up with a solution that make the most sense.
Great, thank you so much again. Now, I know that we still have quite a few questions left, but unfortunately, given our time constraint, we're going to go ahead and wrap things up here. Thank you so much for your thoughtful questions and engagement during the Q&A today. Your contributions really enriched today's discussion. So we're going to go ahead and wrap up. Again, thank you all for your time and your attention during today's webinar. We hope that you found this session valuable, and we really look forward to connecting with you in the future. Of course, if you had some questions that weren't addressed, or if maybe something comes to mind later, please feel free to reach out to us directly at admin@neruca.org. We're always happy to continue the conversation. So again, we really appreciate your time and participation today. Thank you so much, Scott. Thank you so much, Lang. Thank you so much, Jackson and Aptitude, for taking the time to speak with us. But I'm going to go ahead and end here now. Have a wonderful day, and we look forward to seeing you at our next session.
Thank you, Samantha.
Thank you.
Thank you, everyone, for joining.
See ya.